how do I change, anything? And the antidote to that despair is advocacy. It always is going to be advocacy, and not necessarily that you're on Capitol Hill making change. Although, if and when you're able to do that, go and do and speak, because we need people who are doing the work, who are seeing patients, who are actively engaged in healthcare to escalate and advocate and amplify the voices of people that are being marginalized and oppressed. So, like, go and do when you can. Hello, welcome to the Integrated Care Podcast from the Collaborative Family Healthcare Association. I am the production editor, Grace Pratt, and I am joined by two of my fabulous co-hosts today for what I know is going to be a really meaningful and hopefully helpful conversation, which we will get to that in just a moment. But first, we're going to start the way we always do with our introductions and icebreakers. So this is a little bit related to our topic, but it got me wondering. And, after years of doing these icebreakers, I can't remember what we've done before and not. So we may have already done this before. But my question is, well, I have two questions for you. My first question is, what is one of your pet peeves? But then as I came up with that, I thought, well, that sounds really negative, and that might start us in a really kind of complainy place. So my follow-up question is, what is something that bothers other people, but like, you don't care, it doesn't bother you at all? So those are kind of my flip sides. What's your pet peeve, and what's your, I don't know what it would be called, your stray peeve? It's nobody else's. It's, I don't know, something that bothers
these
other
days
people
the
about
kids
you.
call it the ick. What gives you the ick?
Right?
Ick.
But
Yeah.
then also, what does it for other people that you don't care about? And so
Right.
you already heard both of their voices, but kind of going around the circle here for me to do our introductions. First, we have Jen Thomas.
Okay. Hello, everyone. I'm Jennifer Thomas, family med addiction med physician in Morris, Illinois, and co-medical director at CFHA with my good pal Laura Sideri. So, okay, what is my pet peeve, or what bothers people about me? Like pet peeves, or no,
like your
more
pet peeve, what irritates you?
what
But then
irritates me.
also, what's something that bothers other people that
Other
you don't
people,
care
but I
about
don't
at
care
all?
about. Yes. Yeah. I guess I'd probably go to like the good old marital, person I live with, and he'd probably say, the way I load the dishwasher, like apparently there's a proper way to do it, and I put things in wrong places, and then I get cranky if he's like correcting me of like, this is too close to the heating element at the bottom, the plastic will melt. And he's a sweetheart. I don't mean to like, think he's this, or just paint him as a, OCD kind of guy. He's amazing. But yeah, probably just those little like kitchen-y things of like, this is the right way to do this and that. And I'm like, I don't care. Just throw that crap in there and there'll be soap and hot water. Yep, that's me.
And then what's
That
one of your
sounds
pet
like the equivalent of which way should the toilet paper go on the toilet paper
Yes.
roll.
Yeah.
Yes.
Yeah.
There's a lot of controversy
I
over
just
that.
heard something about that on the radio, and there was, I don't know if there's a study, there's always a study, that under is more sanitary, because if it's over, there's more chance of germ exposure. I was like, no shit.
Interesting. We should do a poll. Do you put your toilet
Yeah.
paper?
And that's something that I don't care about. I could give two whatevers about like, is it over, under?
Do
If
you
it's
have
there,
toilet paper? That's
yeah,
what
puts it on the roll besides me, because I feel like everybody in my family is allergic to restocking the toilet paper on the roll. It's like they would
You
rather
know
just
what I
not
think makes
acknowledge
a
it.
difference in that? I have the toilet paper rolls that it's just a hook. Like, you don't
Oh,
have to squeeze
okay.
the thing together and pull it
Okay, you
off.
just
And
slide it on.
for some reason, even just for me, that just makes
Yeah,
it so much easier. You slide it
easy.
off, you slide it on, it's easy peasy. The
boom.
whole, like, I don't know,
Yes,
fighting
You
with
that
fit
little
it in the
spring
hole and
mechanism.
yeah,
yeah.
that's, I don't know. So
Yep.
if you're having that problem, switch your toilet paper holders. Let's throw an
Life tips,
expensive
life hacks
solution.
from Integrated
Not
Care.
affordable roll. But what is one of your pet peeves, Jen? What's
Ooh.
something that gets on your nerves?
The kids in the socks. I feel like I'm always this like constant parade of like sprinkled dirty socks throughout the house. Like there's a trail of where they've been with, their dirtiness. And I'm like 24/7 picking them up and throwing them in the laundry. But hey, if that's the worst thing they do, it's more than okay.
Absolutely.
Yep.
Well, thank you. I'm so glad you're here this morning. And next we have Monica Harrison.
Hello, everyone. Monica Harrison, licensed clinical social worker, clinical trainer, and implementation coach at the AIM Center. Well, I don't have a lot of pet peeves because I think five boys, you tend to just learn to really just let stuff go. Like I'm just tossing stuff in your room and closing the door so I don't have to see it. But I will say, if you want to find the way to tick me off, and it doesn't happen often, but if you want to do it, you could try spitting on me, or you could decide that we're on a phone call and you're just going to hang up without letting me know that you're getting ready to go or hang up because maybe the conversation isn't productive. If you want to see me crash out, you would try one of those two things,
I
and
feel
it
like
wouldn't take me long to get there.
those are not like small annoyances. Those are really rude things, Monica.
Listen,
Yeah.
I,
That's fair.
why you can't keep, listen, I've worked with a lot of, I have been called all kinds of derogatory things, all kinds of B's, all kinds of racial slurs. I have heard it. Nothing sends me to the top than you deciding you're going to spit on me or you deciding you just going to hang up on me. Nothing sends me there faster than that.
Well, that's valid, Monica. And I
Yeah,
vow to never do
absolutely.
either of those things.
Girl, like, and I pride myself in being able to, even when I disagree, like we could disagree and everything's still gonna be all love. Like we still gonna be cool after. That's just how I roll.
Yep.
Jen, you do that, we
If
probably
I spit on you, we're done.
It's gonna be the end
You're
of
dead.
the
I'm dead to
podcast.
you.
The podcast will not survive.
The podcast will not survive it because it's just not gonna work out for you.
Okay, that's all right.
So those I would say are my pet peeves.
Okay.
Fair enough.
And what's the flip
things
side?
that other people like, probably I would say, I was just listening to somebody talk about kids on an airplane. I just tune it out. I think I've just become so like I really I just tune it out and also have a high level of grace for no pun intended, but high level of grace for those who are traveling with kids and know how hard that is, or with 17,632 kids like Grace. Like you just, so I would say I know a lot of people that really bothers them. They feel like, why are you traveling with babies on the plane and da da da? And I'm just like, they got to get somewhere too. And I don't care. I just tune them out. Bring your earplugs. Be prepared, people. That's what I say.
You're taking public transportation, really. So.
Listen.
Well, well, thank you, Monica. Really glad you're here too. And then I'm Grace Pratt. I am the behavioral medicine faculty at Integra's Great Plains Family Medicine Residency Program in Oklahoma City, Oklahoma. Your NBA basketball champions. We're like real happy here for the Thunder.
Okay, see?
And OKC is on the map. We're real excited about that. It's been the big news here. There was a huge parade this week, and it's been really fun. I will say my kids got really into it. Well, 2 of my 4 kids got really into the basketball, and Luke loves it, and Henry loves it. But Henry, he just turned 10 a couple weeks ago, and bless his heart, he is a morning person. Like deeply to his core. From the time he was formed that way. He came out of the womb as a morning person. And he wakes up most mornings at like 5:15, 5:20. Like that's when he starts his day. And so when it gets to be a basketball game and it's 8:00 at the half, he just can't hang. And so he tried so hard to watch game 7 of the finals. And he was so pumped. He was so ready for us to win. And we won. And he was passed out on the couch for almost the entire game. So but we're celebrating, and we're not going to stop celebrating. Yeah, Oklahoma City, blah, blah, blah. My pet peeve is mouth noises. I struggle, guys. Slurps, crunches, smacks.
So you don't listen to ASMR?
Oh, God.
People eat in the...
No, I'm going to have a panic attack with you just mentioning it.
You mean like this? Like
this? No, I'm not listening. I can't hear. I'm
just slurping my coffee just to mess with Grace.
Sorry, Grace. That, Jen, I'm like,
So you'll
Sorry,
promise not
couldn't
to
resist.
spit on Monica, but you will slurp your coffee right in my ears. I see how we stand. I don't know, what do the
So
kids
it's
say about
mouth
that, Monica? We're like
noises?
beefing.
Oh,
Yes,
yeah.
we're,
Yeah.
yeah, Jen and I, we're beefing now.
You're
It's
beefing
mouth
now.
noises. It's
Mouth
smacking and
noises.
slurping specifically, but even, oh, I just can't. It makes my skin crawl. And there's a word for it. They say misophonia, whatever is what they call it.
Yeah.
And sometimes, and I know it's a personal problem. And so, like, I keep gum. We have learning lunches at work all the time. And like, if someone is smacking next to me, I get up and come to my office and get a piece of gum to chew, because like, if I'm chewing, it's not as bad. And I use my relaxation techniques, but like, it's a problem. So
You are
that's my,
using your strategies.
Yeah, you are.
Okay.
Look at
I
you
am. And
coping.
sometimes it still doesn't work. But anyway, that's my pet
Oh,
peeve.
that would have to be hard when people are eating because
It's
many
real
people,
hard.
maybe me too, I don't know, tend to
Mm.
smack.
Yeah. The
Oh.
worst is occasionally we
Yeah.
have wings at work, and I
Oh.
can't, like, I honestly, I
Well,
leave the room.
that's not a
I
attractive
can't
look
do
for
it.
anyone, right? Just all saucy
Grace,
and
you can't even be cute trying to eat wings. Now, come
No,
no,
on.
it's
no,
so loud and smacky. I can't. Anyway,
messy, slimy.
mouth noises, that's my pet peeve. The thing that doesn't bother me that really bugs other people, that probably should bother people more, is just like clutter around.
Mm.
I think everyone in my house pretty much has some form of neurodivergence, and so we have a lot of piles, and I'm working on it. I'm always working on it, and like, I could spin my
That's right.
camera over. If you're watching on
She
YouTube, there's
if
piles,
she
and I
shows her
Piles.
cleaned
desk
yesterday,
full of books,
guys.
piles
This
of
is like,
books and
I
things.
cleaned yesterday. This is better.
Mhm.
But it's fine. I'll find it. I'll know where it
Yeah,
is. It's
yeah.
there. It's not dirty.
No,
But it's just kind of messy,
it's your filing system.
it's
That's the system.
fine. I don't even see it. So sometimes I really have to like pretend that I'm a visitor coming to like, if I'm gonna have people over, I have to pretend that I'm coming over and like come in through
Yes.
my front door and look around and
Oh.
see what I
Oh,
see that I just am blind to.
yes.
So yeah, don't
Yeah.
expect
People
a
don't
super
always think
neat
about,
house at my
some people
house.
think different, like baseboards. I should have used that one. So
Oh, uh-huh.
I clean baseboards
Uh-huh.
Mm.
routinely.
Oh,
Other people are
wow.
like, who cares about a baseboard?
Mm-hmm.
Right. And so I've heard like friends of mine will be like, who cares? Who's sitting and looking at baseboard? And I'm like,
I
well,
am.
you're sitting in the bathroom, like you're
Yeah.
looking. That's the first
Yeah.
thing you're
Yeah.
looking at is the baseboards in the bathroom. So
Mm.
Oh my gosh.
Oh,
I love
that's
it.
great.
Well,
Oh,
I thank you guys for sharing that. I'm so glad we're here. The reason why I picked that question is because obviously different things are difficult for different people, and we have different pet peeves, we have different things that are tough. And some things are kind of universal. I mean, I think I also would have a real hard time with somebody spitting on me, Monica.
and you should,
Right?
yes.
But we all have different things, and we inevitably will come up and bump up against some of those things that bother us, and even clinically. So, we're going to talk about kind of those patients that come into our clinic in integrated care that we like see them on our schedule and we have to take a deep breath, or some of the different characteristics that are really difficult to manage in primary care, and how integrated care can help with that. Before we do that, I think Neftali would get me if I didn't do a little bit of news and notes in his stead. We are coming up to conference season. We're going to be, for the Integrated Care Conference, our CFHA organizational conference is going to be in Raleigh, North Carolina from October 16th to 18th this year. We're coming back to Monica's neck of the woods. CFHA has some really deep roots in North Carolina, and there's a lot of history there. And I know that there's a lot of excitement to be back. I was in North Carolina for 2 years when I was doing my doctoral training in Greenville, North Carolina. And that's like through friends of friends there is how I met Monica for the first time,
I
because you worked closely
know.
with them.
Like we need a North Carolina. There's a song for North Carolina,
Yeah,
but we don't have anybody to drop things in anymore, I don't think.
I
But
know, I don't think so. Yeah, we miss you, Kevin.
mm.
So we, though, want to invite people to come to the conference. It's always a fantastic time of learning, of collaboration. Also, depending on when you are listening listening to this episode, you may have just a tiny window left to submit a late breaking poster. The deadlines for those is June 30th. And it's also time to be submitting nominations for awards. We have a number of awards that we give to recognize outstanding members of our community, outstanding contributors to integrated care. Those are also due June 30th. And so you may have a split second, depending on when you're listening. But regardless, we hope that you'll join us in Raleigh in October. So we'll wave to Naphtali wherever he is, unable to join us today, and hope I did that justice on our news and notes. So let's transition a little bit to our main topic of our show. Jen, I think this kind of started from a conversation that we were having.
Yes.
At the
It's so funny.
conference
It ties
year.
into the conference.
It
What a perfect
does.
segue,
What
Grace.
is it? This is exciting.
Like legit, like no joke. Okay, so set the stage. It was last year's conference in San Antonio. It was like after a session, I think you were having to go catch your plane in a little while, and we grabbed a coffee and we were just chit-chatting about life and what integrated care looks like in our shop. And you mentioned something that like really spoke to my heart. You're like, I like the challenging ones. I'm kind of the oddball in the clinic where it's like, oh, there's a tough one. I'll go see that person. And I was like, oh, if only I could work with you or clone you and bring you with me back to my shop. That would be amazing. And then we just started chatting about that. And I was like, that's so cool that like that's your baby. That's something that you are drawn to, because I know a lot of us, especially the medical, like run screaming the other direction from the tough ones.
Well,
the
and
heart
I
sink
want to
ones.
add a caveat and clarification to that, because I think what I said at the beginning is really true, that different things are difficult
That's
for
true.
different people.
Yeah.
And a patient who is really aggressive or like doesn't want to be here, doesn't value the work that we do together, those are not the ones that I enjoy collaborating with.
Sure.
But patients who I think a lot of are challenging for a lot of physicians in that they have a lot of medically unexplained symptoms. There's a lot of like comorbid trauma that's mixed up in their physical expression of their symptoms. We've kind of reached the end of, there's certain diagnoses that kind of fall under this sometimes too. People that have like these really hard to wrangle, I feel like, whether it's fibromyalgia or, I'm seeing a lot of like Ehlers-Danlos syndrome now, or other things that medicine doesn't really have a good handle on how to fix it. Or like functional neurological problems, things like that things we used to call somatoform. And I know it's so challenging because, I'm teaching residents every day and I'm reminding them, because they're like, there's nothing I can do for this person. I'm like, oh, well, I want to stop you right there, first of all, because the medicines that you prescribe and the like solutions that you give people for their physical health problems is, but you are undervaluing yourself if you think that's the only thing that you're doing for patients. And that when you see a patient who those things aren't fixing it, that you're not helping them, first of all. But second of all, I love working with those patients because I think a lot of times they get, they see all the specialists, they try all the medications, they land on this diagnosis, but they still don't know what to do with it. And so a lot of my expertise is in understanding like our physical dysregulation and how trauma manifests and treating the deeper underlying trauma that's, if not causing, then like strongly exacerbating some of these conditions. And then in my experience, a lot of physicians are like, oh my gosh, this patient is like, it's so hard. And they're some of the, difficult ones. So those are the ones that like, I feel an affinity
Put us
towards.
back to back, Grace, because I want those other ones.
Yes.
I want the ones that people are like, oh my gosh, here they come. They're going to be loud. They're going to be aggravated, or some people will use the word aggressive, right? Like, I want them. Like, I want them. Like those patients.
This is the perfect team to
well,
talk
like,
about.
teach us the sauce. Teach us the secret
here.
sauce.
So, the truth of the matter is, I just feel like it really ends up being about us and not the patient. Like if you, in either situation, right, of the type of patient that you're talking about that's challenging for whatever the reasons are that you've identified them as challenging, it really ends up being about us, which is why we look at it on the schedule and be like, oh, here, like here they come. It's about us. It's not even about them. And so for me, the patient who is loud in the lobby, who is cussing folks out, right? Like that patient, I'm like, oh, it's like my toddler. I got this all day long. Like I got this all day long.
Yeah.
You have to have some tough skin though.
Yeah.
I was literally talking with yesterday in clinical supervision with someone, and they were talking about a patient that they felt like was really really challenging, and I was like, well, why is it challenging? And then she started to explain why it was challenging. I was like, oh, so it's not really that the patient is challenging, they just have a lot going on. It's a pediatric patient, you're uncomfortable with that, you're having to
Mhm.
also deal with the parents and
Mm-hmm. Mm-hmm.
what that brings, a different layer. So
Mm-hmm.
this is really not so much that the patient is challenging, this is that you're uncomfortable.
Yeah.
Mm-hmm.
So now how do we work at you becoming a little bit more comfortable?
Mm-hmm.
Because it's not about the patient, it's about us.
That's such a great kind of thing to punctuate, and I love, what you're describing, that it just reinforces, like, we have different affinities, we have different things we personally find challenging and things we personally are uncomfortable with, and even I think you nailed it when you said you have to kind of have a thick skin. No, I don't have a thick skin. I'm delicate. Like, I can get my feelings hurt, and that's something
Oh,
that
you
I
got to
know I
know
have
that
to
about
work on.
yourself.
Right.
Exactly. Exactly.
Self-awareness.
Yeah,
Yeah.
yeah, and I'm working on it. We're all working on it.
Yeah.
So let's come back to Jen. As we were talking about how to turn this into an episode,
Mm-hmm.
you were thinking about framing in terms of a little bit of case example, or I wonder if you might share, like,
Yeah.
who are the patients that you find
Yeah.
especially challenging to work with?
Yeah, yeah, I would be happy to do that. I was thinking if it's cool with you guys, could I share like a little vignette? Like I was
Oh yeah.
contemplating yesterday, like, okay,
Yeah.
what really gets me stuck? What gets my PCPs stuck? And so I like
Yeah.
created this hypothetical person and
Yes.
set the stage. Can I share that with you? Is that
We
okay?
like a
Yes,
good role
please.
play, simulated
Okay. All
Yeah,
right.
virtual.
girl.
Give
All
it
right.
to us.
Sounds good. Okay, so our setting is a primary care office. It is Monday morning right before lunch, 11:55 a.m. Here's your patient, Kim, 53-year-old. She was scheduled to see her PCP at 11:30 for a medication follow-up. In reviewing your chart, she has several medical comorbidities: diabetes, COPD, hypertension, depression, anxiety, chronic pain, rheumatoid arthritis, and chronic kidney disease. Kim was running late this morning, so the medical assistant roomed her. But when she comes to give you a report, she's really upset because Kim's appointment's going to run into the lunch hour now, and we barely have time to eat as it is. The MA informs PCP that Kim needs a refill on all her meds. Wasn't quite sure on doses or, which was which, but needs everything sent to pharmacy. And she requests a refill on her hydrocodone. She hasn't heard back from the pain clinic that usually prescribes it. She also mentions that she'd like a different med for her depression. The previous 4 to 5 meds that the PCP prescribed have made her worse. The MA notes from the previous visit that you did as PCP that you've been trying to wean down her alprazolam Xanax dose. She had a psychiatrist that started her on this med years ago, but they stopped taking Medicaid, so now PCP took over this prescription about a year ago. When the MA is updating her med list, Kim comments, yeah, I know I was supposed to cut down on the Xanax to 2 a day, but I've been taking 3 to 4. I'm going to need a refill on that today. You just have no idea how stressful things are for me lately. I can't sleep unless I take an extra Xanax. My son was arrested for selling cocaine again. So now I'm caring for his 2 kids. They're 3 and 5. Oh, the 5-year-old, he's a handful. Trouble at school. They think he might have ADHD, or they mentioned autism spectrum. I don't know. Their kid's mom isn't with them. She had custody when they were little, but then she moved out of state. She has her own mental health problems, but I don't think she really took them to all their checkups. So the PCP does the visit, and before walking out of the room, Kim asks, hey, while I'm here, could you check my ear? I think I have a sinus infection or an ear infection. I missed 2 days at work at the warehouse. Could I get an antibiotic for that? And, could you, while you're here, fill out this FLMA paperwork? I missed 2 days of work. Last month, when I threw out my back, you remember you wrote me that letter that said, return to work. My boss said that's not good enough. I have to have an actual FMLA paperwork or something, or they could fire me. And scene. So those are the ones, these kind of things. I know, is that too messy? But that's what I've been thinking.
No, I mean, I think that's really typical.
Okay.
And,
I
you
love the
know,
O, by the way.
it's
Right?
always the
That's
oh, by the
classic.
way.
It's always an O, by the way. It's classic.
It
Yes.
is. And,
Yes.
so one of the things that I want to say is that, I hope what comes through in our conversation is how much compassion we have for this exact situation, because this is not like a terribly convoluted, extra difficult patient that you made up for our conversation today. Like,
It's
this is,
legit real. All of
it
this
is,
stuff is real. It's not specific person, privacy wise, but
yes,
all of those things happen every day in
every
primary
day. And
care.
it's not unusual
Yep.
to have, you're like, she has multiple comorbidities, and you start listing them off. I'm like, oh, they'll listen that long, and
Right.
then
Could
we
be
start
worse.
talking about the social factors. And then we start talking about, I think that's one thing, and maybe we can start by naming some of the challenges that this patient represents. Coming back to what you said, Monica, earlier, that it's really about us and what we feel comfortable with and what we feel uncomfortable with. Because I mean, it's a beautiful vignette because not only does this patient have a lot of physical health diagnoses, they also have a lot of social barriers that we feel a lot of compassion towards, but also I think there's a lot of stuckness for us as providers when we come up to things that we want to help with that we can't help with. So, in that moment at 11:55, or it's probably 11:25 or 12:25 by the time you're done with the counter and the by the way starts, you can't create a social safety net so that her son can experience, a a change in his addiction that he's supporting with selling and illegal habit. You can't create a safety net or, create a program that gives her affordable childcare and, food for these kids that now she's feeding, or ways to have support for when she misses work. Those are not problems that you can face in that moment. They're things we can advocate for, and I think we have an obligation to move in advocacy and in trying to affect that system change. But it doesn't change the fact that this person is sitting in front of you right now with these problems. And I think that's one of the things that's so challenging about this, is holding all of those things at the same time. What are some of the other things that are here, or anything you want to add?
I think that, well, first let me say, my first non-professional response was, give Kim all the Xanax because Kim got a lot happening to her. I will say that. Okay. But professionally, like I'm just playing y'all out there, right? Okay. But professionally, my mind instantly started doing what we typically do anyway.
Mm,
It like almost comes naturally. We do it with patients, but also thinking like, oh, I hope this provider has a awesome rock solid team
mm,
because they need to rely on their team.
mm,
My provider, in any medical provider, any person is not going to be functioning at their highest capacity if they are hungry, if they are thirsty, if they are not taking care of their own needs. Because I can't take care of someone else if I have a deficit. Like I can't. Like you will do it, it will be patchwork, but you won't do it to the best of your ability if you have a deficit. So the fact that as soon as you said 11:55, I was like, oh, it's lunchtime. Who's gonna make sure this provider gets something to eat, right? Like I'm out, like, oh, the provider is gonna be hungry. It's gonna run over. You already know it's getting ready to go into lunchtime, right?
yep.
Is the MA like, all right, well, that's on the provider. I'm out and clock it out for lunch, right? Like, so this is where, and I'm not saying people give up their own personal needs, but I'm saying this is where it's important for communication as a team.
Mhm.
Because if I'm an MA and I know I'm be like, okay, well, I'm gonna run and grab my lunch. I'm gonna grab Jen. I'm gonna grab you
Oh,
blah blah
yeah,
blah too, right? Like,
yeah,
but this is where
yeah.
that team matters, all the way from the front office who sees that, okay, this patient typically runs late, so then is this someone that we need to consider giving them earlier appointments, right? So now that's an issue that's outside of the provider, outside of the patient. Is that what's going on? Is there a general problem with the provider schedule? So our practice administrator should be looking at that again, outside of our provider, outside of the patient. There are these other things that help make this a bigger situation than what it really needs to be. So it would be important for that entire team to be tapped in, dialed in to the pulse of what's happening in the clinic during the day. You
Mhm.
have no idea from one moment to another if a patient is going to be a quick in and out, or if there's going to be a crisis and next thing you know the patient is there for 2 hours. Like, you don't
Yep.
know, no one has any way of knowing, right? But if you have that rock solid cohesive team, they are relying on each other, they are supporting each other. It is not just that provider's responsibility. Like, the patient is everyone's responsibility and we want them to be doing better. And so I think that lifts, I don't want to say burden because patients are not burdens, but
Mhm.
that lifts the heaviness that
Sure.
comes with those providers who want their patients to be doing better. They want to help their patients. Not only do I have this patient that has all of these medical conditions, but all of that is being exacerbated by the social stressors that she's under. Now she's caring for two kids, and her own kid is facing possibly jail time or whatever's happening there. Like the amount of
Mhm.
stressors that the patient is experiencing, a caring provider is going to be like, oh my, like, how do I, okay, she needs FMLA paperwork. Like, let me fill that out. And if you've ever filled out FMLA paper,
That was
Oh,
a
it is
yes.
not
pain in the
Oh,
easy.
yes.
ass. Yeah.
It
Oh,
is
yes.
not easy, and it's not that quick, and like all the things, right?
Yeah.
And so this is one of those things where sometimes not only do you need to rely on your team, but I feel like sometimes you have to prioritize, because
Mhm.
Mhm.
we cannot do everything for every patient all the time in one visit. And I think
Mhm.
that is what we sometimes try to do. Like we want to fix it. Like we want to fix it, and we want to fix it now in this visit. And that's not always possible. It's just not
Mhm.
always possible. But then that means coming to terms with that inside for us who's trying to
Mhm.
help the patient. I was having a conversation with someone about mom guilt. Actually, someone, Laura, this morning. I was on a call
Nice.
with Laura Sadari, and we were
Yay,
having
Laura.
this conversation about like mom guilt, right?
Sure.
And
It's
that,
real.
and it's not just mom, dads have it too, right?
Sure.
And so it's not
Sure.
just the mom thing, but it's been titled mom guilt. But sometimes the guilt feeling, which just means the things that we internally put high
Mhm.
value on, maybe from societal reasons or whatever cultural, we put value on these things. And then when we can't meet that mark, we're feeling bad, but no one else is, like everybody else is going about their day. It's kind of like the pet peeve thing. Ain't nobody
Mhm.
else thinking
Doesn't bother
about
them.
that. You're the only
Yeah.
one thinking about that, right? Like Monica, you're the only
Mm.
one thinking about them baseboards. Just
Mhm.
you. Like Grace ain't thinking about that clutter. You're the only one thinking about that clutter over there, right? So when we think about
Right.
those pet peeves, we don't care where the dishes are in the dish, right? Like we ain't thinking about that, but you have
Mhm.
internalized that to be a thing. And
Mhm.
so that internalization, I think that we do because we want to help our patients. We care about our patients. Oh, if I don't help them with this, what's going to happen? If I don't address all of these things in this
Right.
visit, what's going to happen? The patient's not going to have, like, we start to go into all of that, and so then we don't do ourselves any justice. And so I think it's important to rely on your team. There needs to be a bigger systems conversation from different people that are on the team: front office, administrative assistant, ma, the pcp, where's your behavioral health clinician, right? Like everybody in this case actually has a role to play, and there's something to be looking at, to
Mhm.
maybe triage some things in advance. Some people have triage nurses that would be able to take on, like, what's happening with the medication. I'm gonna go handle all that while the provider's handling their part and the MA's handling their part. So I think that making sure you have a rock solid team, also understanding that you're one person and you do have to pace yourself. So what does that look like? What's most pressing for that patient in that moment? And how do we handle that? And sometimes it might not be the depression.
Mhm.
And sometimes it might not be the hypertension. What's
Mhm.
most important to the patient in that moment? Because if the patient's importance is this FMLA because I got to work, because I got all these responsibilities, and the provider's importance is the hypertension, so let me talk to you about how you need to increase this dosage, you're
Yeah.
not going to
Well,
get very far with the patient.
she's not thinking about cutting salt out of her diet right now. Like,
Right.
that is not, and I do think that that's important, and one thing that kept ringing out in what you were describing to me, Monica, too, is boundaries. We have to have I think I see so many providers who, out of compassion and out of a desire to be so helpful and help their patients, who just kind of trample all of their own boundaries. They don't hold boundaries with them in terms of what you said. These are not all fixable problems today. And so what does it look like to prioritize? What does it look like to shift some time to share the work among the team? There's a, kind of proverb kind of saying that people say a burden shared is a burden lifted. And it's that piece of, we don't have to go it alone. And we sometimes, when we're like, okay, well, I know that it's hard for you to get here, so I'm just going to do all these things today. We're not doing any of them well. And so figuring out how to prioritize, how to narrow in, makes such a big difference. And we can communicate that in a way that is respectful, that does get to what is the most important, that does preserve, the needs of our patients and also the needs of our providers. Because if we dump ourselves out over and over again and we try to do every single thing for every person every time, we're contributing to our own burnout and compassion fatigue. And then we're not a use to anybody. When we are not having those needs met, when we're not taking care of ourselves, then that leads to so much attrition from the workforce, and it leads to providers that are burned out and teams that are unhealthy and all of those things.
Mm,
And so it can be uncomfortable if you're not someone who's used to setting boundaries to say no. But in the long run, it creates space for the right yes. And at that, it was a real shift for me to understand that when we say no, it creates opportunities for us to say yes when we need to. And, I think about this patient, and there may be times, that, like you said, maybe in the future we can schedule her earlier in the day, but today she's here. We've made a
yeah.
decision that we're going to see her. And so we're saying yes to that. But what do we need to shift around our time so that we can still be available to our afternoon client, our patients? I've been working with a lot of therapy students lately, so I've got clients ringing in my head. But
I think it's really important in that, Grace, like, because some people say, oh, I have a hard time saying no. Well, it isn't always about the word no, which, by the
yeah.
way, no is okay to say, but sometimes it's not
Hmm.
even about the word no. You don't want to make a choice for the patient. Give it to them. So
Hmm.
here are the things I hear you having concern with. Here are the things that are really important for us to address. That's a lot for our time just today. So we're going to have to schedule another visit. Which two? Right? When the
Hmm.
patient comes in and they have the long list, because I've had these too, where patients have written things over the last 3, 4 months to come in and talk with their provider about, right? Or their therapist, because I get it in therapy too.
Yeah.
Write it down that they're going to talk about. It's a lot. There's a lot to cover.
Hmm.
What top two, or what's the top thing that we need to address today? Because out of everything you said, these are the things that are most concerning. Which of these things would you like for us to address today? And put it back
Yeah.
on them. It doesn't have to be your decision.
Yes.
You can put it back on them. Like,
And
you've given me a lot. Where we're going to
that
start today?
that really good quality agenda setting truly is life changing. It changes the encounter, it's collaborative with the patients. And I mean, Jen dropped in the chat that, when you're not setting boundaries, it's just not sustainable. And that's the honest truth. You can't go on like that forever. And so we need a different way and a better way. So
Mm.
I wonder, Jen, like, what are some of the things that you're thinking, coming into this in that physician role? Or what do you need from your team? What do you hope for?
Yeah, that's a really good question. I was just kind of thinking in my own brain of like, okay, so we were talking about what bothers you. So me writing this vignette, like this is showing you stuff that bothers me. So like unpacking that a bit. I think you'll see in the vignette, I guess I have challenges with setting boundaries, and I've gotten better at this at time, but it takes time with patients with particularly controlled substances. As a provider, as a young provider, there's like an old adage of like, oh, when you start practice, you're going to get a lot of people drug seeking. They're going to come and see what they can get from you. There's system pressures with, the sway toward let's deprescribe opiates. Benzodiazepines chronic use is a real challenge. And then you learn enough to go, oh wait, now you can't just stop them abruptly because then they'll have benzo withdrawal, but you can inherit patients. Like I think that's what I was speaking with her with the whole like, well, a psychiatrist started me on this 10 years ago, so it must be okay. And then now you own it and you're on the line with your, know better, do better, your license of like, is it right to just keep hitting refill each month? And I know that PCP struggle with this. And I know that it is a harder, longer conversation to talk with people about why taking Xanax 3, 4 times a day may not be the safest, best thing. It takes more time to have that conversation, have a plan to deprescribe when you're trying to do the right thing, all the while knowing with competing demands that when we're looking at metrics aren't bad. It's all about context, though. If they're going to rate us poorly with satisfaction or be upset with us, yell at us, complain, make complaints, that stuff happens of like, they didn't give me
Mhm.
my Xanax. I ran out, I had withdrawal, and like a pressure for providers to deliver patient satisfaction, that it's those dual competing things. Like, what's the right thing? Do I satisfy this ask if I ethically think this is safe or not standard of care? Because I'll tell you, it's a hell of a lot quicker just to hit refill. When I'm going through my in basket and there's 40 refills and I go, ooh, we've hit refill a few times on this Xanax, it'd be better, smarter, to have an engaging conversation with her about coping skills and deprescribing. But I got 3 patients waiting and I got to get out the door in 5 minutes to pick up my kids. I'm going to hit refill. Like, it happens all the time, so teams. I think the secret sauce here, I'm here for you guys, is teams and support, just so that PCPs know that you don't have to handle it alone. Because it feels like that. It feels like sometimes you're in an exam room and someone comes with you with all this life and they just plop it on your lap, like, fix me, fix this, and do it now and do it in 5 minutes. And I'm not saying that that's not possible. And I think we all got into this to help people, but it's very challenging to then toggle between what's right, good standard of care, what you should do, and what time allows. I mean, there's a lot of push and pull there. And I think end of the day, providers kind of just get, a lot of us kind of get through the day. I'll tell you, with the add-on, I tend to be the, fine, here's your antibiotic. Fine, I'll bang through FMLA because I do it all the time. I can get efficient with it because it might be quicker and easier for me just to do the thing instead of enforcing the boundary. And I know that's not great, but I'm guilty of that. And I know a lot of providers are.
Well, and another ways that boundaries come through in what you were just describing, Jen, is when people come to us and they do have unrealistic expectations that you're going to fix all of the things, or they're bringing their suffering, and some of that is on ourselves, that we're seeing suffering and we put on ourselves that it's our job to fix it. But sometimes patients come with that expectation that I'm suffering and it's your job to fix it, so make me stop suffering. We have to also, beyond what we're saying to the patient and what we're saying no to or saying yes to in practicing good medicine, we have to have internal boundaries to know that our patient suffering, we care deeply about that, but it's our patient suffering. It's not our suffering. And we have to be able to draw some limits on, you are not a magician and you are not God, and you cannot prevent people from having suffering in their lives. And we do everything we can to come alongside with compassion, to make recommendations, to treat, to all and everything in our power to alleviate someone's suffering. But we also need to recognize that not all of that suffering is within our power to alleviate. And regardless of whether our patient has that expectation that you're going to fix it or not, you have to also know what your limits are and to be able to let go of the things that we can't control. And like,
Yes.
that'll preach, right? Like that
Preach.
is the
Yes.
the life lesson. But when we carry all the guilt, or when we take on like, there's this thing and I can't fix it, and so I'm a failure. There's this thing and my patient is still suffering, and so I must not be meant for this.
Yep.
We're in the wrong spot.
Yeah, and I think it's important to highlight, because I don't want it to also get lost in the sauce, as they say, like the systems issues, right? So like the system is set up to make people think that it's a fix it, right? Like fix it, like fix it.
Is.
And it
Yes.
is reinforced with satisfaction surveys, which are
Yes.
good things. I'm not saying don't do satisfaction surveys, but when we know that there's rating and we're going to be rated and this is going to bring our rating down, and how does that impact reimbursement? And we have to see, we can't allow more time for education around, well, maybe I'm going to have you see the behavioral health care manager before I continue to prescribe this, and here's why. And then we'll all have a conversation. I might not be able to have as much time to have those conversations because I have back-to-back patients. I got to see 32 patients a day, right? Like some of these things that are systems-driven issues that are really not about patient quality. It's not taken into consideration what the provider has been taught in training, the values of the patient. There was a triangle that I had a provider who used to use it, and I forget what she called it. She learned it in her training, her residency training, but it was this triangle, and it was about the patient's value, the 3 things to consider when making decisions with patients and providing information to patients. It was the patient's values, what the research says, and providers' comfort level. And the importance of taking all 3 of those and making decisions, right? Like, I'm going to consider what my patient is asking for and needing. I am going to consider what the research says, but I'm also going to think about my comfort level and value as well. All three are
Mhm.
important because the research is not always culturally appropriate,
Sure. Right.
right? Then we have what people want or need or think they need,
Mhm.
right?
Mhm.
And that is going to drive their level of buy-in. But then you as a
Mhm.
provider are legally, it's another
Mm.
system,
Yeah.
responsible. So you have to think about your comfort level too. And all three of those things I think are very important. Decisions are not always very black and white. They're not always cut
Yeah.
and dry, right? And so that's just the real of it, that we are in
Yeah.
a system where some things are set up for us that aren't necessarily very helpful and don't help us
Yes.
in what we're trying to do around providing quality for our patients that could get us these better patient outcomes and build our relationships and engagement, which we know has a high proportion of impact on patient outcomes, right? But the system is still operating in the old way.
And, when we're talking about obviously our bias is that integrated care is the answer to a lot of this, and I don't think it's just bias, but this is the integrated care podcast. And so that's the solution that
Hey,
we're going to bring and advocate for. But I love, when we started this conversation, Monica, you were like, what needs to happen with the office manager? What needs to happen with our front desk staff? What needs to happen? And when we talk about integration and integrated care, we're not just talking about the clinical delivery of interventions. We're not just talking about, we put a therapist in a clinic, we're integrated. Great. No, you're not, because it's all of these levels of an organization. And when we talk about like true integration, true behavioral health, like incorporation into the work and family integration and all of those things, it is at every level. So just what happens in the room that the patient sees in that specific clinical encounter is really just a piece of the whole situation when we're talking about it. And we need these values and we need this integration at the microsystem level, within the team of providers, at the larger system level, whether it's the clinic, the healthcare system, the national healthcare system, the broader systems of our society. And so I think that's just a really important acknowledgement. And I think sometimes when providers are frustrated, and I know I have heard this from people in the past, we're fighting the good fight in our clinics and we're doing as much as we can with the resources that we're given. And then when we get up a level, there's not recognition of what we're doing, or there's not support at a local policy level or, a state or national policy level for what we're doing. And that's why one of the things I say to my residents constantly, to all of my learners, is it can get discouraging when we open our eyes and when we say, okay, I'm going to, because it's a privilege not to see, right? When we ignore system problems or when we ignore places where marginalization and oppression are happening, that's our privilege. And so, but when we open our eyes to them and when we look full in the face of those problems and of that suffering, it can get overwhelming and it can get discouraging and it can feel like, well, I'm one person. How do I change, anything? And the antidote to that despair is advocacy. It always is going to be advocacy, and not necessarily that you're on Capitol Hill making change. Although, if and when you're able to do that, go and do and speak, because we need people who are doing the work, who are seeing patients, who are actively engaged in healthcare to escalate and advocate and amplify the voices of people that are being marginalized and oppressed. So like go and do when you can. But even thinking about what does it look like to advocate in my clinic? What does it look like to advocate in my community? And when we turn towards community and we turn towards looking for the place where we have a sphere to affect change, all of that ends up connecting and ends up making change. And that is how we continue the work. That is how we fight the despair that we feel when we start to look at the big picture problems.
What advice can you give to the burnt out PCP that feels kind of hopeless to change systems? I hear a lot from providers of like, yeah, I tried in my own clinic to like advocate for better team-based care or, system level change. and no one listens and they don't do it. And so I just disengage. And I think that's kind of the end stage of burnout is the quiet. Like, people rattle the cages and, hey, this isn't working. And then when they're so far burnt out, it's just silence. They're like just so checked
They're
out that
done.
like they come in, they clock in, clock out. They're not even thinking about being a part of a change because they're hopeless. Like, what do we do for them? I feel that a lot. Or how do you pep them up? How do you coach them up of like, don't quit, don't give up? Because I think that's a lot of them, unfortunately.
I think what we know and we've seen, even working with clients or patients, the importance of knowing that you're not in a silo by yourself, right? So, can you provider, is there another provider, even if it's only one? Is there another provider? Is there a
Right.
nurse? Is there someone else that is like, yeah, I'm with you on this,
Yeah.
because you need to know that you're not in a silo by yourself.
Yes.
I remember very much feeling that way as a behavioral health person coming into the medical field, being supervised by a nurse, feeling very much like they do not understand. Like they do not understand the things that I was working in dialysis. Like they do not understand the things that I am saying, right? That from a
Hmm.
behavioral health standpoint, it felt very siloed. I was the only one in that clinic. When I started to find organizations where there were other people, also some of them in silos and some not, some were on teams. When I found, there was nephrology association. When I found collaborative family healthcare association, I was like,
Preach.
okay, right, like, all right,
Yes.
like
Yes.
when you're able to find your people
Yeah.
and your other person, that like when you have those conversations with them, not that y'all are out here like saving the world, sometimes people are, but you're able to have those mutual conversations. You don't feel like you have to explain every single thing. There's a rejuvenation that happens. Like when you hear people talk about going to the conference, the CFHA
Hmm.
conference,
Hmm.
afterwards, there's an additional fire, right? Like, okay,
Yes.
let's go. What am
The
I fighting?
spark.
Like there's a spark because you're around other people who
Hmm.
have some similar vision. We don't all think the
Hmm.
exact same. A lot of us are in different types of clinics, different types of populations doing different things, but there's a spark and the energy of the spirit of it, right? Like,
Yes.
okay, yes, I can do this. Let's go. It is 51st dates. I tell people that all the time when they're like,
Hmm.
I feel like I keep saying the same thing. It is
It is.
51st dates.
Just
It
accept
is.
it.
And you just have to know that it's
Yep.
51st dates.
Yep.
That's it. And
Keep
so
doing
you don't have to push too hard to wear yourself out, but just know any and every opportunity you have to be like, what? Our A1C numbers aren't that good? Mm. I wonder if we tried the integrated care thing and we were able to get some other people on the team, da da da. Drop
Yes.
it. You dropping the
Yes.
seeds. Now,
it.
at
Yes.
some point, something is going to get watered and start to grow, but it
Yep.
might take 51st dates before it gets there. But
And
the
at some
Yes.
biggest thing I would
point,
say is like stay in there, provider, and find your
Stay in
people.
there. Yes. And
yes.
don't feel like you can't voice, like name it. You can't. Sometimes in some systems, the worst thing is providers don't have psychological safety, so they don't feel comfortable even naming what's dysfunctional because then, oh, then
Mm,
I'm the pessimist. Then I'm bringing the team down if I'm talking about what's not working. That's hard because I think we have to start with, hey, it's not meant in a spirit of you're not doing your job. It's like, let's just objectively look at it. What could we all do to make it a little smoother tomorrow for all of us? So keep
Yeah.
trying, keep speaking up, because the minute you disengage and get silent and don't even, name what's not working, then we don't have hope to integrate and make things better.
And we have to be connected to meaning. So connecting to the meaning and purpose of what we're doing in whatever that way that looks for you. So for some people, it's, thinking about those specific patients that are like those watershed moments of that have left a mark on you that you feel connected to. Sometimes it's going back to like, why did you come into this in the first place? But I think we can get lost in the details of, like you said, the schedule and the meaningful use numbers and the all of the data, but like, who are those stories that remind you of why you're doing the work that you're doing, and sharing those stories and connecting with people who get it too, just like you're saying, even as we work on having boundaries and enforcing those in ourselves practically, in the clinic room and internally in how we're doing our own work.
And share the wins. I think
Hmm.
we get so used to what's not going well, what's bothering us, that we
Yes.
forget to share the wins, because those
Yes.
are the things, right? Those are the stories, like what Grace is talking about, that keeps us going. Share
Yeah.
the wins. Why can't we start a meeting sharing the wins?
Let's
Why we
do
got to
it.
start
Yes.
with all the action item things that we were supposed to do last time? Like, can we start with sharing the wins? Like,
I
what
Yes.
is
love it.
I
going
love that.
well?
Yeah.
Hmm.
Let's start.
Hmm. Yeah.
This is where we would drop. All I do is win, 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 no matter
No
what.
matter what. Monica, you may just have to brush up on your editing skills so
Yeah.
That
we
is
can.
not my that is
Your
not my ministry.
podcast DJ, whatever.
It's okay. You could just keep performing for us live.
Yeah, that works
Love
too.
it. Monica's version for the asterisk at the end. This has been, I just think, such a invigorating for me conversation in terms
Yes.
of, we've done a lot of reframing. We started with what's challenging and we talked through, all of the different ways that things can be challenging, but then some principles of how we connect, how we engage, how we support each other and keeping going and keeping doing the work. And I think at its core, we believe in the work that we're doing and we believe in the mission of integrated behavioral health, of family-centered care, of all of the work that we're doing. And I hope that there's something in here that resonates or inspires or comes alongside and kind of shares that, when you feel that frustration, you're not alone. And we're here, and I know that there are so many more of us and people in our communities and in healthcare who believe this. So thank you guys so much. I hope that this was kind of validating and reassuring for you some too, Jen, and as we're talking about
Absolutely.
this.
Gives
Yeah.
me a spark and a hope to literally take into the exam room. That's where my next stop is. So carry on,
Love
right? Do
it.
the work.
Yes.
Yeah.
Well,
Good.
we miss
Thank you.
you, Bridget and Naftali,
Yeah.
but Monica and Jen, thank you for being here. Thank you to our listeners, and we'll talk to you again next month.